they choose not to enroll because they have experience with Medicaid, and they find that when they enroll, they still can't find a doctor to see them because Medicaid pays so little that very few doctors will take a new Medicaid patient. So they roll on out of the ER when they're feeling poorly, just like they always did. Nothing in their life has changed. Why should they bother to enroll in Medicaid just to make some bureaucrats happy? The fact is that people, the uninsured, do not find value in the insurance coverage that is currently available on the market. And part of that reason is because we've loaded up mandatory coverages onto insurance policies so much that it is no longer a good value for the money. I'm going to skip the next two things, I think. I don't know what's going to happen, but I do want to move on to probably the next to last slide. Go ahead. I tried to get slick with my slides once. It's the biggest mistake I've ever made. No, the one before that. Yeah, no. Try to get all the arrows up there. Anyway, the essential problem in healthcare is not fee-for-service, and it's not wasted money. The essential problem in healthcare is third-party payment. Third-party payment has a consumer paying premium to an insurance company that pays a doctor to deliver a service. It's a triangular relationship, and like most triangular relationships in human affairs, it doesn't work very well, because one point of the triangle is always feeling left out and insecure about what the other 2 points of the triangle are doing. So the consumer doesn't know when he goes to visit a doctor who his doctor is working for. Actually, he does know. He knows his doctor is being paid by the insurance company and not by him or her as a consumer. So who is the doctor reporting to? Who is the doctor accountable to? It is not me as a patient. It is Blue Cross or Cigna or Aetna that pays his bills. He who pays the piper picks the tube. And this is a violation of one of the most intimate relationships in our lives between a patient and a physician. And the insurance company has become way too interested in what's happening between that physician and that patient. And the insurance company tries to police their behavior and make sure they don't do anything wrong. They want to make sure the doctor's not spending too much or too little time with me, that he's prescribing the right medications, not the wrong medications, and he's telling me to quit smoking and stop drinking and exercise and eat well, and all these things that are frankly none of the insurance company's business. Now, if we go into a public program, it will be the government that stands in the shoes of the insurance company. So the government will be scrutinizing every transaction between patient and physician. And I think that is a system that the American people are not going to appreciate very much. Thank you very much.
Well, I had a PowerPoint, but the power went out on the Senate side of the Capitol Hill today, so I had to write my notes on old-fashioned paper. So I hope I don't lose people without having fancy slides like Greg put together. But I did think that Greg did a great job in really highlighting really what the dilemma is. And I get asked a lot of questions about, why is this health reform process taking so long? What's wrong with it? Why aren't they moving the bills? I thought we had deadlines. Well, I think it's a classic illustration of trying to mesh policy and pay-fors. How are they going to pay for this healthcare scheme? Everyone has a grand idea. They've got all these bells and whistles, all this bureaucracy, all this Washington-based healthcare solutions. But at the end of the day, now they've got to figure out how all the pieces come together and how they're going to pay for it. So I think Greg did a great job identifying what the policy challenges are. And I'm going to touch on the cost problems that they're now facing in this healthcare debate. And I'll start off by highlighting, what has been the timeline in this debate? Well, the President said this was one of the most important things that he wanted to get done. Senator Kennedy had promised a bill in the middle of May to be released and marked up by the end of May, beginning of June. That timeline slipped. Finance Committee was going to be soon, a week behind them. Thus far, we've had 2 delays in the Health Committee. They're still marking up their bill, which is interesting, after about 3 weeks now of markup. Something that was only supposed to take a week, I think, was what it was originally scheduled for. The Senate Finance Committee still has yet to release their bill after months and months of negotiations and trying to figure out how to fix this dilemma of paying for a massive health care reform bill. And in the House, I thought for sure their bill would have been released by now, but they too are stumbling across these problems of how they're going to pay for this and how do you pay for it and make the policy still work. So that's the dilemma that I think is facing any type of a healthcare reform proposal that tries to centralize all the decisions and have all the problems solved in Washington. So I'm going to do a little bit overview of what the bills actually do cost, what are the challenges that are up front. We really only have one somewhat complete cost estimate of the bills, and that's on the Health Committee. So I'm going to really focus a lot of my attention there. But the first thing we need to realize is the CBO cost estimates, let's remember, are a 10-year window. So you're only getting 10-year estimates. You're not getting long-term estimates. And let's remember, the government always says something's going to cost less than it really ends up costing us. So don't be confused by 10 years being the end of this program. It actually will go on. And I like to highlight the S-CHIP bill as a bill that I worked a lot on. It was a $40 billion program over 10 years. And the cost skyrocketed now to 75, I believe, was the final number in the bill that was passed. That's a significant change in spending. Once the bill was expired, they added more spending on. So you can't look at 10-year windows and think that that's all the bill's going to cost. But even having done that, CBO thought that the original version of the Senate Health Bill was going to cost close to about $1.3 trillion. Recent discussions in the House bill before the bill got kind of pulled away to the back again to get reworked was, I think, about $1.5 trillion was of the original estimate that CBO had for the House-based bill. So we're talking trillions of dollars. This isn't the $635 billion down payment that Obama said. This is the full $1 trillion bill. Well, the Senate Health Committee then said, well, we better figure this out. $1 trillion is an awfully high price tag to ask the American people to foot during a time of economic uncertainty. So they went back to the drawing board and kind of reworked some of the policies so that they would back into a CBO score to make the score lower. Well, that got them to a revised figure of about $789 billion over 10 years. But I want to say again that it's still an incomplete score. That score misses one of the largest pieces in the health care reform debate that hasn't been really addressed, which is a massive Medicaid expansion that's in these bills. In all the CBO scores, that's the one piece that's been left off the entire score. So now we've got $789 billion in a health committee bill that doesn't include a massive Medicaid expansion that some estimates put at between $500 billion and $900 billion. So we're back to still a $1.3 trillion bill, easily, once all the pieces come together. So that's a very important thing to remember. Also, these bills the CBO estimates have significant impact on the deficits. Again, at a time when we're seeing already $1 trillion deficit, over the next 10 years, the Senate Health Bill, the original score was going to add another $1 trillion over the next 10 years to the deficit. Then they whittled it down and said, well, it's only going to be $600 billion. Well, again, not until you include the Medicaid component, and then the Medicaid component pushes you right back up to deficit spending. So it's very important to understand the magnitude of these bills. We are talking about legislation that's in the trillions of dollars, and there's no way, no matter how you slice it, by the time you add the pieces all back together, it still gets you to about $1 trillion to $1.5 trillion. Again, far less than the $600 billion that President Obama had stated in his budget this year. Well, what were the key elements that are costing so much in this legislation, even without the Medicaid piece? It's the subsidy piece. As Greg pointed out, when you're going to require people to buy health insurance with an individual mandate, now you've got to make sure that they can afford what you're mandating them to buy. So it forces the government to make subsidies at very high levels. The Health Committee bill in the Senate, the original bill, had subsidies going up to people earning 500% of poverty. I quit calculating at about 300% of poverty when I do that. 500% of poverty is practically the entire country.